بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه أجمعين. Today our lecture is about female fertility hormone. The lecture will be presented by Dalia Ibrahim Waqalla, Assistant Professor of Clinical Chemistry. Objective of this lecture: by the end of this lecture, the student should be able to describe female menstrual cycle and associated hormonal change, define menopause, know definition of primary and secondary infertility, understand the causes of infertility. The key female hormones from the hypothalamus: gonadotrophin releasing hormone, which stimulates anterior pituitary to produce follicle stimulating hormone FSH. FSH is responsible for follicular development and ovarian function. Also, anterior pituitary produce luteinizing hormone LH, which stimulates ovulation and production of corpus luteum. The menstrual cycle. In the menstrual cycle, we have phases. The first is follicular phase. This starts from day 1. In day 2 and 4, a small group of follicles grow and develop. Day 5 to 7, one follicle dominate. Ovulation, LH, surge and release of oocyte. The second phase is luteal phase. In this phase, the formation of corpus luteum is begun. If pregnant, sustain endometrial lining until formation of placenta. Not pregnant, progesterone level decrease and cause endometrial shedding. Here is the summarization of menstrual cycle, the different phases of the menstrual cycle. Menopause. The menopause is cessation of menses for at least 12 months. Loss of ovarian follicular activity leading to hormonal insufficiency. The age for menses is range from 45 to 55 years old. Menopause symptoms include hot flush and night sweat, depression and anxiety, sleep disturbance and mood change, problems with concentration and memory, sexual dysfunction and vaginal dryness, joint pain, headache, and weight gain. Infertility. Infertility is inability to achieve pregnancy after 12 months of unprotected regular intercourse. Primary infertility. Primary infertility is mean or it is a term describe a couple that has never been able to conceive a pregnancy after at least 1 year of unprotected intercourse. Primary infertility, that is mean there is no pregnancy during their life. While secondary infertility means or describe couple who have previously been pregnant at least once but have not been able to achieve another pregnancy. Five hormones aspect of infertility. CDC report that 22% of women have trouble getting pregnant. The causes include 21% is anovulation, 14% tubal damage, and 6% is endometriosis. Overall, 28% of cases were unexplained. There are 5 key hormonal aspects to infertility. Number 1, ovarian insufficiency. As follicles fall, estrogen is still produced, but ovulation does not occur. In the luteal phase deficiency, ovulation may occur, but progesterone levels are insufficient to sustain pregnancy. Number 3, in polycystic ovarian syndrome, most common endocrine disorder in women of reproductive age. Thyroid deficiency, also implicated as a cause of infertility. And number 5, stress, high or low cortisol level can affect the ability to conceive. Women with infertility also tended to experience monthly hormonal change such as high FSH level on day 3, follicular phase, reflect ovarian insufficiency. Low estradiol and progesterone on day 21 could indicate low egg reserve. High estradiol and low progesterone in luteal phase indicate non-ovulation. High testosterone and dehydroepiandrosterone with high level of LH relative to FSH. This is point to polycystic ovarian syndrome. Now we can summarize the laboratory workflow in female. First, we measure basal body temperature. If it is normal, we measure serum progesterone and obtain endometrial biopsy. And if it is normal, we evaluate for structural abnormality of reproductive tract and hypothyroidism. If there is high temperature, the body temperature is high or abnormal, we measure serum progesterone, estradiol, testosterone, FSH and LH, and also obtain endometrial biopsy. If the result is abnormal, low progesterone and out of phase endometrium suggested luteal phase defect. We have 3 cases in workflow of female. Number 1, if we find estradiol and testosterone low, then we measure FSH and LH. If FSH and LH are high, this is suggested primary ovarian failure. If FSH and LH are low with low estradiol and testosterone, this suggested hypothalamic pituitary abnormalities. The second case, if when we measure estradiol and testosterone, the result either normal or low normal, then we measure FSH. If FSH low or normal and LH high, in these cases we suggested polycystic ovary syndrome. If we measure FSH and LH and the result is low, this suggested secondary ovarian dysfunction. The third case when we measure estradiol and testosterone and the result is high. Then we measure FSH and LH. FSH and LH result if high, this suggested hypothalamic pituitary abnormalities or ectopic production. If FSH low or normal and LH high, this suggested polycystic ovary syndrome. And if FSH and LH are normal, this is suggested primary ovarian dysfunction. So, as summary, the diagnosis of female reproductive problem is based on the measurement of estradiol, testosterone in combination with FSH and LH. Each result is indicate one of the common problem or disorders of female reproductive system. This is all about female fertility hormone and hormonal change during menstrual cycle. Thank you for listening and